Most of us are familiar with the consequences of peripheral vascular disease in diabetic patients, and we have all seen examples of severely ulcerated limbs. Using traditional recanalization methods, these limbs were often difficult to treat successfully, and even if attempted, the procedure was both long and strenuous for both the patient and the radiologist. Now, with the new tools available to us, there is an option in combination with the subintimal approach to make the procedure much more viable than it had been beforehand. The development of the new Terumo J guide wire and the new recross catheter by Clearstream have made a substantial contribution to subintimal recanalization. Subintimal angioplasty is a well-established technique to treat long superficial femoral artery and lower limb occlusions. One of the disadvantages of this technique is that after crossing the lesion with the loop technique, advancing a balloon catheter is sometimes very difficult in patients with highly calcified vascular segments, especially in lower limbs. Also, balloon puncture is a well-known problem in relation to local calcifications. The recross catheter is designed with a very high pushability to pass through even highly calcified subintimal channels and also to support wire during recanalization. The new balloon material is also strong enough to withstand most damage by local calcifications. One of the most important applications for this technique is severe critical limb ischemia, resulting in ulceration of diabetic limbs. The result we wish to achieve with this procedure is a full recanalization of the affected vessel and with that saving of the affected limb. Looking at an example of severely ulcerated foot. Unless the vessels supplying this area can be successfully recanalized, the only choice for the treating specialist is often amputation. Bypass surgery is often not an option due to the general profile of these patients. Most are older, diabetic, and already suffer from vascular comorbidity. So the procedure has to be as efficient as possible. The subintimal approach, in combination with the recross catheter and the newly developed Terumo J-tip wire, make this possible. I want to show you some of the products we have on the table today. First of all, standard puncture needle, a standard wire, and a standard sheet. This is a 5-French sheet. On top of that, we use the products I just described. This is the Terumo J wire, specially designed for subintimal passage, and we have the recross catheter we're going to show to you in the animation later on. In the following few minutes, we will describe the procedure, tools required, advantages and risks in more detail.
For this example of a subintimal procedure, we will be using a recross catheter over a 0.035 Terumo guide wire with the addition of a vessel access set. The procedure example will be based on a long calcified lesion in the femoral artery. The Terumo 0.035 guide wire is probably the most efficiently shaped wire to conclude this procedure successfully, as it combines a flexible J-tip with a semi-stiff body, which makes it more maneuverable in the subintimal layer. The advantage of the 0.35 recross catheter is to provide the guide wire with the necessary support to make the bypassing of the lesion successful. The highly pushable inner shaft using Clearstream's crosslock technology is the major advantage of this over the wire catheter. It enables almost 100% of both push and torque to be transmitted from the hub right to the tip of the catheter without any buckling or concertina of the balloon when obstructions are encountered. The distal part of the catheter in the area of the balloon is very flexible to facilitate navigation and tracking of the guide wire. When an obstruction is encountered, the catheter's cross-lock action transmits forward push fully to the tip. The new QuadFlex balloon has also shown to be extremely burst resistant in a recent multi-site registry of the recross. No bursts occurred despite the highly calcified vessels involved. Both the Terumo guide wire and the recross catheter are particularly suited to the ipsilateral approach, which has a major advantage in the degree of control the interventionalists have during the procedure. This will be the procedure explained in the next few minutes. The location and correct positioning of the entry point is crucial in the ipsilateral approach, as the guide wire needs to be in the superficial femoral artery at the beginning of the procedure. The correct entry point can be located either by fluoroscopy or ultrasound, and is approximately 5 centimeters above the profunda artery in the common femoral artery. This is important, as an entry point which is too proximal will make it difficult to control bleeding, while going too far distal will make it impossible to go into the SFA. Carefully advance the Terumo guide wire down the vessel towards the lesion, following with the catheter once the lesion is reached. The tip of the wire will encounter resistance and move towards the wall of the vessel as further push is applied from the base of the wire. Follow the wire with the catheter and bring up to the vessel wall in order to provide purchase for the catheter to support the wire most effectively. This will assist the wire entry into the subintimal layer. Further push will make the wire loop back onto itself. This loop is crucial. It provides a safe progression of the wire through the subintimal layer with a low risk of sectioning the vessel. Advancing the recross through the subintimal layer just behind the loop will prevent a spiral building and will provide additional support to go through highly calcified lesions. The loop will extend until its furthest point reaches the end of the occlusion, where lack of pressure from the intimal layer and continued pressure from the outer wall will induce the wire to slip back into the true lumen of the vessel. It is believed that the forward pressure required to continue through the intimal layer at this point is higher than the force required to re-enter the lumen. This point is clearly visible on the screen as the diameter of the loop reduces when re-entering the vessel to adjust to the smaller vessel diameter. Once this point is reached, the catheter can follow along the wire in the subintimal layer in order to place the balloon alongside the occlusion. The progress of the catheter along the wire will allow the operator to undo the loop and park the wire along the artery beyond the occlusion. Once the balloon is in place at the most distal point in the lesion, it is inflated once or several times, pushing the calcification towards the lumen wall. The number of inflations will depend on the degree of calcification. In long lesions, the balloon can be pulled back into the more proximal parts of the lesion and inflated again. This is repeated until the occlusion has been fully ballooned. Once satisfactory blood flow is established, the catheter and wire can be retracted. The vessel is now allowing blood to flow freely.
The strength of the recross catheter in combination with the flexibility of the Terumo wire as well as their availability in 0.18 and 0.14 sizes also makes it possible to carry out successful intervention in seriously calcified lesions below the knee. Their strength and pushability make it possible to advance well into the plantar arch with full control of the wire and without the need to pull back the catheter in order to inject contrast. As a result, cases which would have been considered not suited for endovascular treatment beforehand can now be treated successfully, and that with avoiding limb loss, even in difficult cases with highly calcified lesions.
The recross is also available in 0.018 and 0.014 guide wire platforms, suitable for severe cases in narrow and distal vessels. Balloon lengths of up to 22 centimeters are also available for treatment of very long lesions with a minimum number of inflations. The pushability of the recross platform makes such balloon length a realistic option.